Our first speaker. Our first speaker is Dr. Sendzischew Shane. So Dr. Shane completed her medical degree at the University of Miami. She also completed her residency, chief residency year, and her fellowship in gastroenterology at the University of Miami Jackson Memorial Hospital program. She's also been the recipient of a T32 research fellowship and is currently a candidate for a Master's of Science in Clinical and Translational Investigation at the University of Miami. She continues to practice at the University of Miami in the Division of Gastroenterology with a research and clinical focus on motility disorders and women's health. Today, she'll be presenting When It's Not Just Constipation, Dyssynergic Defecation, and Pelvic Floor Dysfunction. Thank you.
Thank you for that introduction, and thank you to Dr. Weiss and the Department of Medicine for the invitation to speak today. So today I'm going to cover an entity, pelvic floor dysfunction, specifically dyssynergic defecation, which is heavily under-recognized and therefore underdiagnosed. So I thought I'd bring it to everybody's attention. So the objectives for the case presentation will start, and then we'll define dyssynergic defecation and pelvic floor dysfunction, review the diagnostic workup for patients with constipation and suspected dyssynergia, and then discuss the treatment algorithm for patients with dyssynergic defecation and pelvic floor dysfunction. So our patient is a 55-year-old woman who presents to clinic for her annual evaluation. She has no chronic medical conditions, and she reports she is overweight but has been managing better in the last few months by eating mostly at home, as most of us are, and she's lost 10 pounds intentionally. On reviewing her medications, you notice that your nurse has added Miralax PRN to her list of medications. On further questioning, you discover that the patient's been having worsening constipation over the last 2 years, specifically in the last few months. She also describes intermittent left lower quadrant pain, with which she can't pinpoint in association to any specific food or activity. She reports that she'll stool about 2 to 3 times per week maximum. She passes hard stool, Bristol stool scale 1 to 2, with significant straining. She does not pass any blood or mucus with her stools, but does have some rectal and anal pain before and after stooling on occasion. When you ask her specifically, she endorses that she sometimes feels the urge to stool, but then when sitting on the toilet, she is occasionally unable to pass a stool, or will pass a small amount and feel like she could still pass more. She'll often sit on the toilet a few times within a short period because she feels the need to stool again. She does state that sometimes she'll have to lean forward and backwards when straining to successfully pass stool, and she has gotten lightheaded on the toilet from straining. She was very mortified when you asked, but then she ultimately did endorse 2 episodes of digital disimpaction within the last year, and she denies any vaginal or perianal splinting to assist with defecation. She'll occasionally find fecal smearing on her underwear, and she has started wearing a liner. She does not endorse any nocturnal fecal incontinence. She reports intermittent chronic constipation on and off since her teen years. She doesn't remember any stooling issues in childhood. She doesn't remember her parents saying anything about that. Constipation was always worse during her menstrual cycle, around mid-cycle, and then she would intermittently have diarrhea or at least resolution of her constipation during her period. She would manage with dietary changes, increasing water intake, occasionally over-the-counter stool softeners and laxatives, and during her pregnancy, she required daily Miralax, but after her pregnancy, symptoms would usually improve. She started menopause 2 years ago, and her constipation has gotten worse during that time. She has no family history of colorectal cancer, and she had a colonoscopy at age 50 with an excellent prep, no polyps, and some internal and external hemorrhoids noted. Her next screening is due at age 60. In terms of an obstetric history, she has had 3 pregnancies and 2 deliveries. Her first child was born vaginally. He weighed 8 pounds 5 ounces, and she required an episiotomy and vacuum extraction. Second pregnancy was a boy, 7 pounds 13 ounces, cesarean delivery after prolonged labor for decelerations. So what's going on with our patient, and more importantly, why does this matter? So in the US alone, over 1.8 million annual outpatient visits stem from the primary symptom of constipation. US physicians annually diagnose constipation in more than 2.5 million clinic visits, and up to an additional 1 million visits nearly address anorectal disorders. And in 2020, the projected annual cost of ambulatory physician services related to pelvic floor disorders, including constipation, is about $83 billion. So when we say constipation, what do we actually mean? If you polled all the gastroenterologists on grand rounds right now, you'd probably get just as many, if not more, answers. The definition varies widely even among specialists, and the consensus statements aren't exactly consensus. But we say that normal stooling frequency is anywhere from 3 times a week to 3 times a day. And there's obviously a large variation within there. It's characterized by difficult or infrequent passage of stool, so less than 3 times per week, hard stool, or feeling of incomplete evacuation. There are subgroups, including slow transit constipation, normal transit constipation, which is primarily identified by passing of hard stools, and then defecatory disorders, which are the most common cause of constipation. So when I say pelvic floor dysfunction, what do I actually mean? It's a broad term that encompasses multiple entities. It includes urinary incontinence, fecal incontinence, dyssynergic defecation, and pelvic organ prolapse. For the purpose of this talk, when we're referring to chronic constipation, I'm going to discuss mostly dyssynergic defecation and pelvic organ prolapse, although fecal incontinence could certainly have its own talk. Common presentations of these two entities include constipation, patients with alternating bowel habits where they'll have episodes of constipation followed by profuse diarrhea, a feeling of incomplete defecation where they feel like they've stooled, and so they can often even stool up to daily but feel like they're not completely evacuated. Patients can have fecal soiling, which is a small amount of fecal material that ends up in the underwear, or incontinence of flatus. The first population-based estimate suggests that nearly 25% of women struggle with some form of pelvic floor dysfunction, and by 2030, a projected 36 million women are estimated to have at least one symptomatic pelvic floor disorder. Risk factors for pelvic floor disorders include the female sex. There's a preponderance of about 3 to 1 females over males, multiparity, more pregnancies, more deliveries, perineal trauma or surgery. This includes any tears during vaginal delivery, episiotomies, vacuum and forceps extraction, pelvic surgery, prostatectomy in men, and in women hysterectomy, because this changes the angle of the pelvic organs as they relate to one another. Age, in conjunction with these other risk factors, obesity, smoking, poor functional status, and systemic diseases like diabetes, Ehlers-Danlos, and scleroderma can also have an effect. So this slide of the anatomy is not to give you PTSD from your first year of medical school. It's only to remind you that there's an interplay of multiple muscles, both on a superficial and on a deep layer, that are involved in maintaining both urinary and fecal continence, as well as the integrity of the pelvic floor. The image on the right shows the anal rectal angle, and I wanted to remind everybody of the anatomy and physiology related to defecation. So in order to appropriately defecate, stool comes down into the rectum, and then where it reaches the 90-degree anal rectal angle, which is maintained by the puborectalis muscle, which is a sling muscle that attaches anteriorly to the pubis. During defecation, intra-abdominal pressure and intrarectal pressure increases, the puborectalis muscle relaxes, increasing the anal rectal angle from 90 degrees to 115 degrees, and the external anal sphincter relaxes, allowing for easy passage of stool. When that doesn't happen, patients end up with dyssynergic defecation, which is the incoordination of muscles involved in defecation. This can be the paradoxical contraction or the inadequate relaxation of pelvic floor muscles, and or the inadequate propulsive force during attempted defecation. It's important to note that the dyssynergic defecation definition includes both an evaluation of the rectal propulsive force and the external anal sphincter relaxation. It is the most common defecatory disorder, and nearly 40% of patients with chronic constipation have underlying dyssynergia. If you go back to that original number of 1.8 million visits a year for constipation, 40% of those visits, patients probably are suffering with underlying dyssynergia. It affects women 3 to 1, as I said, and the prevalence is unaffected by age, although it is more common in older individuals. So pelvic organ prolapse, and the other pelvic floor dysfunction that we're going to discuss today, is the downward descent of the pelvic organs, including the vagina, uterus, bladder, and or the rectum. So a cystocele is an anterior vaginal wall prolapse, more commonly presents with those patients who have cystoceles more commonly present with urinary symptoms, and rectoceles, which are the posterior vaginal wall prolapse, can present with constipation due to obstruction, straining with defecation, which is essentially when patients are trying to push against a closed door because of the prolapse of the organ, and then fecal incontinence. This can be due to connective tissue degradation, denervation, devascularization, and other structural changes. that can occur over the span of a lifetime, including complicated deliveries. And a woman's lifetime risk of surgery for pelvic organ prolapse is estimated to be as high as 20%. So what do? The first thing, as always, history is key. There are a lot of questions to ask about constipation, not just, are you constipated and what are you taking for it? So you want to explore the bowel habits in childhood. Do they remember their parents saying anything? Dyssynergic defecation is what we call a functional bowel disorder, meaning that it is a learned behavior and usually develops after a patient is potty trained around the age of 4. It usually develops after that time. So what were their bowel habits in childhood? Did their parents ever say anything? Were they constipated as a kid? Did they have to take any laxatives then? Did they have any problems with their bowel habits in teen years? If they were constipated, how did they manage it then? When did they first take notice of the constipation that they're seeking treatment for now? Were there any particular life stressors, any health issues, any hospital admissions, antibiotics? And how do they currently manage their constipation? Are they doing anything for it? Other questions. What are their current bowel habits? We need a lot more information on this. What is the frequency? How many bowel movements do patients have per week? What is the longest they can go without a bowel movement? Some patients, when you ask this question, will report to you that they can go up to 7 to 10 days without stooling. That becomes important because patients who have long periods but with it in between stooling can have rectal hyposensitivity, which becomes a problem with dyssynergic defecation as well. You want to look at the Bristol Stool Scale and use it to describe consistency. That way patients and providers are talking about the same consistency of stool. Is there any blood or mucus in the stool? Patients can obviously have blood in the stool from outlet bleeding from hemorrhoids, but you also just want to make sure that you're not missing an underlying inflammatory or infectious disorder. Do patients have straining with stooling? Do they have to change position to evacuate? Do they have the urge to stool, but then they can't pass stool once they're seated on the toilet? This is a sign of obstructive defecation, which should tip you off to a possible pelvic organ prolapse. Do they have the urge to stool? And when after they return to standing, again, that leads to this idea of obstructive defecation. Any perianal or vaginal splinting to assist with evacuation. You have to ask patients specifically if they use fingers or other devices in their vagina or around their anus in order to help with evacuation. Patients are not forthcoming with this information. Do they require digital disimpaction? If they do, how often? And do they have a feeling of incomplete evacuation? This should be asked of every patient with constipation, but specifically questions for women. Do they have any changes in symptoms with their menstrual cycles? What about any changes during any pregnancies they may have had? And then it's important to take a detailed OB history. How many pregnancies have they had? How many deliveries have they had? What was the method of delivery? Was it a vaginal or a C-section? Did they have any tears or episiotomy? Any forceps or vacuum assistance? All of those factors play into pelvic floor weakness and pelvic floor dysfunction. And then you have to ask incontinence questions. Again, patients are not forthcoming with this information. Data show that patients who seek care for fecal incontinence, of those patients, only 7% actually will give that information to their provider without being prompted. So do patients have urinary incontinence? This is mostly managed by our urology and urogynecology colleagues, but it's important to know the overall health of your patient. And then fecal incontinence. Are they just having fecal smearing, or is it large volume incontinence? Is the fecal incontinence more common after multiple days without passing a stool? That tips us off to this idea of possibly overflow diarrhea, wherein there's actually an impacted large volume of stool in the rectum and liquid stool is passing around the solid stool that's still maintained in the rectum. Is fecal incontinence preceded by urge? That should tip us off that there's possibly some pelvic floor weakness or external anal sphincter weakness, that patients aren't able to maintain their continence, but they do feel the urge to stool prior. And then is there any nighttime fecal incontinence? That usually is more indicative of a problem with the internal anal sphincter. So once you've taken this really great history, now what do? You have to do a digital rectal exam. In the state of Florida, and we're now required to get consent for all pelvic exams, but it is important because rectal exams have been shown to be 75% sensitive and 87% specific for identifying dyssynergia. There's a lot of information that can be gained from a digital rectal exam, especially if you do one correctly. This involves the inspection of the perianal area for visible deformities like large skin tags or prolapsing internal hemorrhoids. You have to assess the anal-cutaneous reflex with a cotton swab. Digital insertion should be done done carefully with a well-lubricated gloved finger. You need to pay attention to the resting anal tone, if there's any pain on insertion, any spasm, if you feel any palpable masses or strictures, which would need to be worked up further, and if there's any retained stool in the rectum. Again, retained stool usually indicates possible rectal hyposensitivity, which is really important in these patients. Fissures are very difficult to identify in digital rectal exam. If you suspect that a patient has a fissure, we recommend doing anoscopy or potentially exam under anesthesia, depending on the tolerance of the patient. Then you're going to ask the patient to maintain a squeeze for 30 seconds. You want to see what the fatigability of the pelvic floor is. Then you're going to ask patients to bear down and stimulate a bowel movement. You want to check for anal sphincter relaxation, if there's any perineal descent that makes you think that there's pelvic organ prolapse, and then check for appropriate recruitment of the abdominal muscles. Patients who have chronic constipation sometimes aren't creating enough intrarectal and intra-abdominal pressures. And then you have to check for appropriate puborectalis relaxation. So once you've done your digital rectal exam and your good history, and you think that patients might have dyssynergia, what do? You refer them for anal rectal manometry. We have 2 labs on campus, one on UHealth Tower and one at Lennar. And what is anal rectal manometry? It's the gold standard for diagnosing dyssynergia. It provides numerical information on resting anal tone, squeeze pressure, endurance of the external anal sphincter, and the coordination involved in defecation. As we've covered already, this incoordination indicates the dyssynergia. Patients can have weak resting tone, weak squeeze pressure, and easy fatigability in patients who complain of fecal incontinence, which can also be seen in patients who have chronic constipation. These 2 entities are not mutually exclusive. Elevated resting tone, what we call anal hypertension, may contribute to constipation, fecal soiling, and even fecal incontinence due to fatigue of the sphincter. And there's a balloon expulsion test wherein 50 milliliters of tepid water are inserted into a balloon attached to a catheter in the rectum, and patients are given 1 to 2 minutes to attempt to evacuate the balloon. This balloon expulsion test can be done separately or in conjunction with anal rectal manometry. An inability to pass a balloon has a high sensitivity for dyssynergic defecation. So when I say anal rectal manometry, this is what we do. We have the patient come in after a prep of only enemas, as we have them lie in the lateral decubitus position, and we insert one of these 2 catheters. These are the 2 catheters available. The catheters each have sensors along the length and an inflatable and deflatable balloon. So when we do the manometry, this is what our software reads out. In the middle, you see what a normal resting tone would look like, as well as the beginning of a squeeze. And this is what dyssynergic defecation looks like on our software. It's not important to learn the different subtypes of dyssynergia, only to know that this is how we diagnose it, and we're able to see the intrarectal pressures, the puborectalis pressures, as well as the internal and external anal sphincter pressures during the anal rectal manometry. So when you suspect that a patient has pelvic organ prolapse, either from your digital rectal exam on anal rectal manometry or from taking an extensive history, you may want to consider getting MRI Difficography. So even though these large rectocele and rectal prolapse may be seen on anal rectal manometry or even on physical exam alone, patients often have equivocal exams and they need to undergo additional imaging. MRI Difficography is a dynamic MRI that evaluates the coordination of defecation and can look at structural abnormalities affecting defecation. Looks at the anal rectal angle, pelvic floor descent, as well as any of these other pelvic organ prolapses. And acute changes in the anal rectal angle during defecation may indicate underlying dyssynergia. There is some controversy over whether or not patients should be in the decubitus position or seated upright for these images, but mostly everyone agrees that MRI Difficography is still the best way to diagnose pelvic organ prolapse regardless of positioning. So what are the options for treatment once you've identified that a patient doesn't just have constipation, that it's actually underlying dyssynergia or pelvic organ prolapse? You know, the first approach is still the same for everybody. It's really important to manage stool consistency. Fiber supplementation, often used, can be really beneficial, but you need to be careful because Patients can often still experience worse bloating with fiber, and if patients have insufficient water intake, this can actually worsen their constipation. You want to review patient medications and look for any medications that may have constipating side effects, and also avoid giving any new medications that may have a side effect of constipation. Maximize any stool softeners or laxatives that the patient may be using or may benefit from. Patients can still have chronic idiopathic constipation or IBS with constipation and have underlying dyssynergia. So it's important to address stool transit time and stool consistency in addition to outlet dysfunction. And you do have to be careful, because in patients with weak external anal sphincters, the risk of fecal incontinence increases as the consistency of the stool becomes softer. So once you've maximized to the best of your abilities the stool consistency, patients need to be referred for biofeedback and pelvic floor muscle training. Biofeedback is the mainstay of treatment, and the goal is to correct incoordination of abdominal and pelvic floor muscles during evacuation, and also improve the perception of rectal filling in patients with impaired rectal sensation. Again, this needs to be done often in conjunction with pelvic floor physical therapy, and results are highly dependent on both the skill of the therapist and the patient's motivation. I mean, just like any other physical therapy, patients need to practice these exercises at home. If you see here a picture of a rose, there are lots of different biofeedback programs, as well as home device units and home device software. This is just one of them, where you can see the flower opening when patients' muscles are relaxing and the flower tightening up when their muscles are contracting. It provides a different kind of visual cue, because patients are often unaware that they are inappropriately contracting or inadequately relaxing muscles. And so there's actually a pretty standardized protocol for how to approach dyssynergic defecation with biofeedback. First, patients need to be educated on the physiology and the pathophysiology involved in their diagnosis. They should be educated on diaphragmatic breathing exercises. There are actually great videos from the University of Michigan on YouTube for diaphragmatic breathing. And then patients, similar to 4-year-olds, need time toilet training. Patients should not be bringing their telephones into the toilet to spend time on Twitter or Instagram or play words with friends. You need to go into the bathroom, do your business, and leave. If you're sitting on the toilet for more than 5 minutes and you haven't been able to evacuate, we always advise patients to leave the bathroom and try again at a later time. And patients should try to defecate at the same time every day to retrain their body appropriately. Then the active phase of biofeedback involves visual, auditory, and verbal feedback techniques, and sessions last between 30 and 60 minutes, need to be done about twice a week. And patients should, if they can't get biofeedback therapy consistently with a therapist, should look into home devices. And then reinforcement needs to be done with a trained professional at identified time points to maintain integrity of the treatment plan. Additional interventions: a multi-pronged approach is needed for patients with severe pelvic organ prolapse. When patients do require surgery, a multidisciplinary approach is often needed, because patients who usually have one pelvic organ prolapse have multiple pelvic organs that have prolapsed. Often patients may need a urologist or a urogynecologist, GYN, and colorectal in on the same procedure. And timing of surgical intervention is important. All patients benefit from pelvic floor muscle training and biofeedback therapy before surgical intervention, regardless of the outcome. So some take-home points for today. Constipation and pelvic floor dysfunction have a significant effect on quality of life and are extremely costly to the healthcare system. Over 40% of patients with chronic constipation suffer from outlet dysfunction, and so patients with chronic constipation really need to have this considered as a part of their underlying diagnosis. Specifically, dyssynergic defecation and pelvic organ prolapse should be considered in all patients, especially women with refractory constipation, and even earlier in patients with associated risk factors that we discussed, like multiparity and traumatic delivery, as well as systemic diseases. Extensive history should be taken with specific questioning in every patient, and because patients just aren't forthcoming with these symptoms, they find them embarrassing, or some people think that it's a natural part of aging, and these particular symptoms really need to be addressed directly. And if a patient is suspected of having pelvic floor dysfunction, we recommend referral for evaluation and advanced testing with anal rectal manometry and/or MRI Difficography. The gold standard for management of dyssynergia is still biofeedback therapy and pelvic floor physical therapy, and patients with pelvic organ prolapse may benefit from surgical intervention, but all patients, regardless, benefit from pelvic floor dysfunction benefit from pelvic floor muscle training prior. So if there are any questions, otherwise, thank you for the opportunity to speak today.
Dr. Sendzischew, that was comprehensive, excellent, and understandable. Thank you so very much. Doctor, is there anything that you can comment on regarding the role of post-pregnancy care that would mitigate the syndrome or make it less common?
So actually, that's a really great question. In France, pelvic floor muscle training and physical therapy is part of all postpartum care in other countries, not so much here, but it's really important to pursue pelvic floor muscle training. Things like Pilates and other pelvic floor muscle strengthening exercises are really key in the postpartum time period. And more importantly, if you did have a traumatic delivery like an episiotomy or a large tear and you suspect that there may be some underlying sphincter damage, it's important to get this addressed early. If it's not done within the first year, the benefit of any surgical intervention after a year diminishes significantly.
Thank you. Anybody from the audience have questions they'd like to either raise their hand or put on the chat? Seeing none, thank you again for this excellent presentation, and we'll continue with the next speaker. Thank you.
Thank you.
Okay, so our second speaker is Dr. Dang. Dr. Dang received her medical degree from Maulana Azad Medical College in New Delhi and completed her residency and fellowship in geriatrics at the University of Arkansas in Little Rock. She completed her MPH at Tulane School of Public Health and Tropical Medicine. She is the Associate Director for Implementation and Outcomes Research in the Miami VA Geriatrics Research, Education, and Clinical Center, or GREC. Her areas of interest include telehealth, chronic disease management, high-need, high-risk patients, and their caregivers. She's also the Innovation Core Lead for the multi-site Elizabeth Dole Center of Excellence in Veteran and Caregiver Research. Today, she will be presenting practical tips for telehealth visits for older adults.
Thank you for that introduction. Okay. So with the push to increase telemedicine during COVID-19, there's been an exponential increase in virtual care, and a lot of the visits are now being offered by video or telephone, as the case may be. This is great. I love telemedicine, so this is perfect. The only thing, that's been that has propelled telemedicine into the forefront. But it really puts some of our older adults at risk, and therefore we really need to pay attention to the fact that these older adults who may have a challenge to receiving care virtually are not left behind with no care. And as that is an important issue, I just wanted to present some practical tips for telehealth visits for older adults, and not necessarily address all the barriers to telehealth, but just kind of mention those as I give this talk. So we know that there are a lot of benefits of telehealth for older adults. It includes access to clinical care. Patients who are older and have trouble with transportation or getting to the facility are able to be seen in the comfort of their own homes. This is especially important in patients who may be rural or remote. I mean, a 15-mile drive in Miami may be more valuable or time-consuming than a 60-mile drive in a rural area. So it's really important because it gives them access to care. It may also be valuable for people who have functional limitations or disabilities. And of course, it provides safety during the pandemic. It can address social isolation because they can see somebody or they can talk to people while they're at home, and safe during the pandemic. It also offers support, not just to the patient, but also to the caregivers, and gives a modality for education, COVID, about their chronic conditions. And I'm not even bringing up the opportunity to educate the residents, fellows, and medical students using technology, because that, of course, is another great added value of telemedicine. But we also know that there are some challenges to the older adults, again, doing video visits, and therefore, again, I wanted to mention some real practical tips on how to assess an older adult using technology during this time. So the learning objectives for today are to identify and prepare older adults for a successful telehealth visits and some tips for that, how to adapt a telehealth visit to evaluate the 5 M's of geriatrics, how to engage care partners via telehealth, and identify and address social isolation. So the first thing that we want to know is how to prepare older adults or veterans for a telehealth visit. And what is the best way to meet the patient's needs? Is it really important that they have a video visit, or would a telephone visit be adequate for whatever you need to address with that patient? We need to also recognize the barriers to performing some of these telemedicine visits with older adults. And then we need to recognize that there are steps that one could take to prepare older adults for a successful telehealth visit. And then recognize some website manners, even in this preparation phase, that are that need to be considered as we get ready for these visits. So choosing the telephone visit versus a video visit, again, what is the best way to meet this patient's needs, and identify if the patient has the technology access, willingness, and ability to use a video visit, or would prefer to use a telephone visit. And verify then that all the technology tools are in place, because you might, on a checklist, get that they have the technology, but then they might not work when you're actually trying to set up the visit. And of course, we have to encourage that care partners or caregivers attend the visit, because they might provide collateral history and also help with the technology, which is often a challenge for older adults. So this is an example of a screening tool that could be used. This is, there's no one perfect screening tool, but how do you identify who's the best person to do a video visit versus a telephone visit? And just to identify whether they have the needed technology, you can ask them questions about whether they have a computer, a smartphone, a tablet, and then do they have the ability to download the application that you may need them to download from the App Store or wherever, so that they can actually do the visit. Now, of course, given that we are now able to do visits on FaceTime or Google, etc., or Zoom, some of these things may or may not be important, but it's still something that you need to assess. And then, do they have an email account and an internet plan, or a connection, a connectivity? Even if they may have a data plan, they may not have connectivity where they are. And do they have somebody that might be able to help them with the video visit? So as we assess this, there's a lot of talk about how older adults are at a risk of getting left behind in this rush towards telemedicine. As I mentioned earlier, we have to assess whether they have the technology access, the willingness to use the technology, and the ability to use technology. It's been reported by several people that up to 40% of the older adults population over the age of 70 may not have the technology access, willingness, and ability, or even more, to be able to do a video visit. And then a lot of patients that have sensory impairment. 75% of people over the age of 75 have some hearing loss. Of course, that can often be addressed by using hearing aids and other assistive devices. But despite all that, up to 20% of people, even with corrective measures, may not have adequate hearing to be able to do a proper visit using technology. Up to 70% of the oldest old have been reported to have trouble with doing video visits. So we have to keep that in mind as we are trying to schedule somebody who's 87 years old for a video visit. And the people who are at the highest risk of not being able to do these video visits or not have the adequate tools, etc., are men who are often unmarried, Black or Hispanic, and then people who have lower education, lower income, and poor self-reported health. And as we can see, it's often those people, these are the people who often have the greatest need for care, And they are the ones who are facing the greatest barriers to care access during this time. So once you identify whether the patient is the right candidate for a video visit, how do you prepare them for the visit? You need to get a consent for the video visit, explain the process to them, ask them who else they would like to attend the visit with them, and actually really encourage that. Set up the technology, and this needs to be done optimally before the video visit. Even we try to do it a day or two ahead of the visit. Set up the connectivity, make sure that the lighting is right, kind of train them how to focus the camera, set up the background, not just for the patient, but for yourself as well. Make sure you remind them to bring their adaptive devices, whether it's a hearing aid, a pocket talker, whether it's their glasses. Make sure that you remind them to write down their questions. Again, nothing different from a regular visit, but this is even more important because everything is more highlighted during a virtual visit. Talk to them about privacy and confidentiality. They are at home. There are other people in the home that they may or may not want to be part of the visit. So make sure that they realize that and have the ability to lock the door, so to speak, so that they can have the privacy they need. And this is important not just from your patient's perspective, but also from your own perspective. So we've had an instance where we were seeing a patient with a fellow, and somebody walked into the room, not the patient's room, but the fellow's room, while we were doing the visit with the patient. So that needed some coaching and counseling for the trainee. So remind your trainees of that as well, and teach the patients and the care partners what to expect. As you're starting the visit, again, do this at least 15 to 20 minutes before the start of the visit. Allow time for troubleshooting, setting up technology. Make sure that you follow all the safety guidelines. Make sure you know it is the right patient, what the location is, and alternative means of contact. Very, very important, because about a third of our visits kind of have challenges during the visit, in which case we have to switch to a telephone visit. So we always have that backup set up, where we have a backup conference line actually set up that we give the patient. We have the patient's phone number. We make sure that we know who their emergency contact is. We've had, it could be that the patient has some kind of an emergency during the visit. So how do you get 911 to their address without knowing where they are located? Again, and ensure privacy and confidentiality. Introduce to them the roles of all the people that they will be interacting with. Confirm again that they have their aids to make sure that they can hear you, see you, establish rapport, and then again have a backup plan for troubleshooting if there is a problem during the visit. Website manner, this is really, really important. Again, as I mentioned, make sure that the patient and you are in a private, quiet area without any distraction. Make sure everything looks professional. And they have, again, their hearing and visual impairment devices. This, I cannot stress this enough. And make sure that, again, the background and the clothes for you are adequate and are so that the patient can best visualize you, even if they have visual problems. Look at the camera and not at the screen. So if you have a camera that's set up on the upper right corner and you keep looking at the screen, the patient is going to see one end of your face, and that's not what you want. You want to simulate eye contact like you're looking at the patient. And it's very interesting because in this dynamic, if there's a patient and a caregiver at the other end of the screen, this is very different, because the body language in this case is not similar to what you do when you're in a room, because then you can just turn to the caregiver and ask them to answer a question, or look at the patient and ask them to answer a question. Here, everybody's in one room possibly, or could be in different locations, in fact. But you have to use different body language to kind of make sure you're getting the answers that you want, or information that you want from the person that you want it. Make sure that you speak slowly and clearly, and give enough time for the delay that's caused by the technology as well. And this is especially important if the patient has cognitive impairment. During the visit, again, no different, gather history from the patient and the care partners as appropriate, but again, using more body language, and you may have to be giving more directive questions to or the care partner is saying, could you answer this question, or could you address this for me? Because it's not where you can just turn and kind of, focus attention on a specific person. It's really important to identify what tools you'll be using to assess the patient, and we'll talk about that in a minute. Ask them if they have the needed help. There have been a lot of changes during the pandemic where patients' home health aides was lost, or any community services or agencies that were providing nursing may have kind of stopped their services. So you have to make sure that they're getting the needed help. They have access to the supplies, medications, food, etc., and of course educate them about COVID while while we're still during this period. Make sure that the patients write down the care plan and make plans for continuity of care and follow-up. This is important because oftentimes when the patient is doing a visit in person, at the end of the visit, you might give them a printout sheet saying, here's like your plan for today, and here are the consults that you can expect. Here's the lab you need to go to. You're not giving them a paper right now, because not at least at that time. But you do have the opportunity to either mail that later, put it in the electronic medical record so they may be able to access it if they're able to do that, or make sure that there is some plan for follow-up care for these people, so that they don't get lost and fall through the cracks. There are several advantages to a video visit which we have to acknowledge. This is like as close to a home visit as possible without doing the home visit. You can actually use this opportunity to do a home assessment almost, and to understand the patient's social context of whatever is affecting their health. You can do a medication reconciliation and actually ask to look at the medications and the glucose logs or blood pressure logs. So there are advantages. You also have to remember that this is really an intrusion into the patient's privacy that they may or may not want. There are patients who look really nice and well dressed when they come to the clinic, but they may be not having such a good living environment, or maybe hoarders. They may not want you to see what your home environment looks like. Those are the patients that may not agree to a video visit, or they may agree, but then they're kind of giving up a part of their privacy. So you have to really appreciate what they're doing to be able to have you do this visit in their home. How can we adapt a telehealth visit to evaluate the patient? So I'm going to talk about that in the context of the 5 M's. The first M in this case might be mobility, so functional ability, home safety, then the other M's as we go through them: medication, mentation, multimorbidity, and what matters most to the patient. If you're trying to log in, and this is, you see a patient's home setup, it could be this setup on the left side or on the right side. So is who lives in a very cluttered environment, in which case you have to make sure that you talk to them about safety and maybe removing some of that clutter so that they can move around without having an accident in that house. Or it could be this other home that you're seeing where everything is very clean and properly positioned. So that in itself will give you an insight into what you need to address with that patient. Does that patient need a home safety evaluation, or are they doing okay? You might log in and you might see this other, look where you see this really dark room. Of course, if you've done like a setup properly and somebody's kind of gone ahead of you, hopefully, and told the patient to turn the lights on, etc., then you won't find this. But if you do, then you know that you have reason for concern again, that there is a safety hazard there. Or you might see a cat, which is another safety hazard potentially. So again, it gives you an insight that you might not get when the patient comes to the clinic to see you. You can do some kind of an assessment of their mobility and their ability, their functional ability, keeping in mind that this other person, the therapist, or is not the person who is in the home. So this person may or may not be there, and you're doing this assessment without either anybody to help you, or it might be their caregiver who might be able to be this person and can help you. And how much you can or cannot assess will depend on the setup of the home. I mean, is there enough space in that home to make the patient do a timed up and go test, perhaps, like, walk 3 meters, turn around, go back and sit in the chair? or not. Or you might even see that the patient may have trouble getting up from the chair. Again, you have to really remember that this all has to be done within the context of making sure that the patient is safe. Granted that they may be getting up and trying to get out of the chair and go to the bathroom even on their own when you're not doing the assessment, but you want to make sure that at least while you're doing the assessment, you're keeping them safe and then using the information that you find to provide any interventions that you think the patient may need, whether it's a physical therapy consult or home safety assessment, a walker, a cane, etc., whatever you think that you have gleaned from that visit that the patient may need. Make sure that you gather information on their ability to do their activities of daily living and their instrumental activities of daily living and provide whatever interventions they need. For the medications, which is the second M, you want to make sure, of course, ideally that you've told the patient to make sure that they gather all their medications, like the brown bag that they are supposed to bring to the clinic, and have it ready for you when you call in. But that may or may not be the case. We often find that the patients have forgotten or just didn't get it together in time. So, it's helpful in that situation to ask them to show you where their medications are. Of course, again, done within the context of safety. If the patient is using like a computer that's a desktop, they may not be able to kind of point it to where their medications are kept in some cabinet in a different room. But if they are using a cell phone or something like that, they may be able to kind of walk to show you where the medications are. And again, you have to do that, making sure that they're safe. These pictures give you a lot of information about the medications. Are they medications like this where you see there's a clutter? I mean, this patient is probably going to forget to take half of his medications because they're not organized. While this other patient has everything organized and probably has like, here are my morning meds, here are my afternoon meds. So, you do much better with that patient in terms of getting them to take their medications. For mentation, you have to make sure that you review the record to see if this patient needs any assessment for their mentation. Are there any warning signs in the chart? Again, now remember, a lot of this may not be needed if you already know the patient really well, then it may just need a follow-up for some of the things. For the medications, it's an especially good opportunity, but for some of the other stuff that I'm mentioning here, it may only be valid if it's a new patient or a patient that has had a change in their status, etc. So you want to look for warning signs of that suggest problems with memory, which could be like weight loss, missed appointments, no recall of recent appointments. You could do different tests that you are comfortable with and that you build, that you practice with. It could be a MOCA. There's a blind MOCA that can be done, which is a 22-item questionnaire instead of the 30-item questionnaire that doesn't involve, some parts of the writing and all that. There are ways to share your screen and do a MOCA as well, which are not that perfect, especially if technology is a challenge. You could do a mini cog. Also, don't forget to screen for depression, anxiety, and social isolation. And again, a lot of this does not have to be done by, it can be done by some clinician. It doesn't have to be the physician. It could be the nurse. It could be a psychologist. So some part of the team that could go ahead and do this ahead of the patient or after the patient, depending on what the challenges or concerns identified are. For multi-complexity, and most of the patients at this stage are older, have multiple chronic conditions. So this is often the case, more often than not. Make sure that you involve the care partner in performing whatever physical exam you're doing, reviewing the available data. I mentioned this is a time where they often walk into the clinic and they say, oh, I forgot to bring my blood pressure log. Well, here they're at home. To go ahead and tell them to go get their blood pressure log, so you don't miss that part of the information. Again, this is also a way to recognize other barriers that may limit the patient's ability to take care of their chronic condition, because you're seeing them in their environment, in their home. So you might recognize certain challenges that they're facing that you may or may not be able to address, but at least you can discuss them and see what the possible options are. Assess not just the patient's, but also the care partner's needs and provide support and education and access to resources. And then again, very important, especially during this pandemic and even otherwise, is to understand what matters most to these patients. These are complex, older adults. You now have a window into their home, so you can use environmental cues to understand what's important to these people. What is the value to them? Like, what are they trying to live for? In some cases, if they're really old and frail, like, what is it that they want to accomplish in whatever time they have remaining? So identifying that, using the environmental cues, discussing that with them will help you align the care that you're trying to provide to these older adults with their own goals for their health or their life. And then documenting, especially advanced directives, end of life care, goals, etc., is also very important. Engaging care partners is important. As I mentioned so far, care partners play a very valuable role in managing older patients. They help them with their medications, they help them with doing needed exercise, any change in the status. It's even more important in patients who have dementia, and then, or more important in patients who are remote. Okay. Again, you have to identify who these care partners are, like who are these people, what are the different roles that they play. There may be a group of people that are supporting an older adult. Some may or may not live with them. Some may live several states away, etc. So what are the different roles that they're playing? How can you engage them in the visit? So very important to try and see if they can all come to the visit, right? Because telehealth offers that opportunity, which is often not available otherwise. And this is really one of the key benefits of doing visits via telemedicine. And they can also help with the actual technology use. You can get collateral history, you can provide education and support, and then have the partner help in following up of the care plan. Again, they can follow up on whatever the plan is that you've come up with, and then be part of the care coordination effort. So sometimes it's really important that the care partners often have their own sets of challenges and may be having issues with burden, anxiety, etc., that they're dealing with, because they are part of this, maybe the 24/7 care that they're providing this older adult. So it's really important to find a window of opportunity where you can talk to them alone to identify what are those stresses. They may not be willing to share that in front of their, the patient, their loved one, because they don't want them to stress out. But it's really important to figure out what are those challenges and see if you can address them, either by sending them to a different provider, adding some community resources, etc. Also, during this time, it's really important to address social isolation, which is maybe getting better now with everything relatively trying to get back to normal. We'll see how that goes. But important, because all this distancing leads to more isolation, more loneliness, etc. So it's really important to identify that, ask them. Of course, patients may be reticent or reluctant to talk about it, but again, try to ask them about it and see what you can help with. You can ask your community of providers in the clinic, your support staff, to be the people that kind of reach out to these older adults, make like a monthly phone call to check in socially, ask your friends and family to step in and increase the number of calls they do, refer to online and community resources. And these are some of those that actually give museum visits, a visit to a zoo, etc., that may help with their social isolation, etc. So what are some of the take-home messages about seeing older adults by video visits? Home telehealth requires preparation. It's not really simple. It is preparation that is required at a system level, so at the UHealth level, at a clinician level, and at the patient and caregiver level. It's important to build rapport, and it's important to be flexible and patient, because you have to kind of set up for the visit. During the visit, things may change, and they're always you have to be prepared to have a backup plan, etc. Adapt your visit, your exam, your clinical history taking, etc., to the needs of the older adult. So you have to be flexible in that as well. Make sure you involve the caregivers, care partners. use your team. You can't do it all yourself, so make sure that you members of the team have different roles and they can do different parts of the assessment. And referrals to community resources are especially important. Arranging care coordination and follow-up care is really important, and also determining if they actually do need a face-to-face visit. If there's something there that bothered you that you feel you didn't quite get right, you want to make sure that you see them face-to-face if needed. And it's really important, again, in this time, because for some patients, in-person visits are hard, but telemedicine visits may be impossible for some of these older adults. So do not leave these older adults behind and let them fall through the cracks, because it's often those with the greatest need for care that face the greatest barriers to care, and we want to make sure that we address these older adults as well. That's all I have. These are some references. Thank you.
Thank you, Dr. Dang, for a very timely presentation that all of us, given the fact that we vary between 30 and 70% telemedicine visits now, these pointers are very useful. There was one question on the chat from Dr. Bocanegra regarding any tools or devices available for helping with physical exam. And so I'd like to call everyone's attention to our telavigilance campaign run out of UHealth, where we have Tyto devices that are available to appropriate patients so that you can do not only vital sign images, but vital signs and pulse ox and so forth, but all Bluetoothed into the visit, but also able to examine the ears and the throat, listen to the heart, listen to the lungs. It's quite advanced what can be done. The only thing you can't do is a blood test, and that will change soon as well. So all of these things are capable with new technology that is currently available to everyone. Sabrina Talderone has sort of led our initiative in that effort, along with Christina Rubio. So if any of you are interested, please contact Sabrina for further information. Stuti, we have 1 minute. Is there any other questions that people would like to give us on the chat or raise their hand? Well, thank you very much, Stuti, and I thank both presenters today for excellent grand rounds. We appreciate it. Everybody be safe, and we'll see the faculty later this evening with an update from me. I don't remember what time, but it's in your calendar. Have a nice evening and a nice day.
Okay.